So when we started, we used to have this superhighway, and we have now come out of the superhighway. You can just go use the URL up there, and when you use that URL up there, you can visualize all our systems. You can visualize all these registries. Why? Because there's nothing to hide. If it's a client registry, it's a registry for all clients. If it's a health worker registry, it's a health worker registry for every health worker, including your own counties. If it's facility registry, and again, community unit registry, terminology, all this is there. And I can say that comfortably, we are already there. The other thing is that we have a point of care systems, which you are working on to make sure that they are aligned. For now, we have 3 point of care systems. Initially, in 2020, we were talking about having one, which was purely Afya KE. But because of the issues of consortium and the ministry, now we have Kenya EMR and Tibabu coming on board. We have infrastructure backup, and I want to agree with the members, Waziri's here, where we have distributed the devices. You don't talk about internet. Everything is there and is working very well. So in terms of, again, regulations, we have been guided very well. And most of these applications in green, you realize that they're up and running. So as a country, we are coming from somewhere. We are coming from a physical database. I remember very well when Dr. Ganda, our chairman, Waziri, was my medical superintendent in Voi County Referral Hospital current. And that time, we were everything paperless. At the same time, we started as those were 2006 there, a way of trying to digitize using Excel, and that is a passion I followed all along my life. So again, now we have EMR systems, which came in 2010, and from 2010, we moved forward. We are now talking about cloud-based EMR systems, which came around 2021, 2022, post-COVID. And now we are in a position whereby we can use mobile applications, and this has been, as a country, our digital evolution in this country. So next is about where we are now, and now we are talking about digital health ecosystem convergence, and this means that we need to have an enabled digital health environment. For us to achieve this, we are talking about issues to do with teleradiology and telemedicine. As we talk now, there is a facility in Garbatura in Isiolo County, which is having telemedicine together with KNH, and it has been running like that for the last around now 3 years. Again, we are talking about the Taifa care systems. These are our point of care systems, the EMR, the HMIs, as we call them in the facilities, which capture our patient level data. I want to say that the problem with this is, as a country, we started on financial note. When we started 2003, we started thinking about, can we capture only financial information? And Waziri Dr. Ganda will tell you that while in Voi, those guys used to switch off the fund soft at every 30th of the November. And they will tell you we have system issues until you pay 300,000 so that they can make it up and running. So we started there, but now we don't need to think about money again alone. It's item as a country for interventions. We think about the patient holistically. From there, we have also what we call the National Logistic Management System, the KEMSA. Already we have a product catalog of all the drugs from PPB, which you can always go inside the catalog and get any drug, so long as authorized in the country. Again, for us to move forward as a country digitally, we need to do medical research so that we can continue innovating on a daily-to-day basis. Together with that, we have the medical devices. And as a country, the current government envisages and plans to distribute over 75,000 devices. So far, we are at almost 20,000 in the counties, and we are proceeding to make sure that we have 100% coverage. Again, we have the enterprise bus service, which gives the health information exchange, and with this purely is to make sure that at least we can uniquely identify our client, we can uniquely identify the facility, we can uniquely identify the healthcare worker who is providing this service, we can uniquely identify that kind of service. If it's a lab test, radiology, if it's a disease, and even if it's a medicine. So we have the bus, which is purely to assist us in that. Again, we have the funding agencies, the consortium, and the DHA and SHA, whereby we are working as a team. And with all this now, when we bring all this together, we have what we call a convergence of digital health-enabled environment. So with this, As our dream now, which actually we are actualizing, we are moving far as a country. What are the benefits of this environment? One is to make sure that at least the Kenyan citizen can always access to specialized expertise, because they will not be seen by quack doctors, they'll be seen by qualified people, they'll have the right medicine. And again, to the health service provider at all levels, again, they can consume health information exchange at any given time, and again, they can interface without any challenge. Again, healthcare funding, the SHA team can always be able to make sure that they reimburse on time and the way it is. The national and county government, we can come together again and make sure that we optimize the processes we do on a day-to-day basis. So that has been, and this actually enabled, it will enable us to create more innovative healthcare systems. Remember, we are coming to a time whereby now we cannot silence the issue of artificial intelligence, machine learning, and data science. So we are going to high because we have a lot of data to make sure that we can do a lot of health innovations in this country. Where are we today? What is the status today as a country? Today, as I was born in that 1st August, we can talk about health facility digitalization, and we can demonstrate even the dashboards and what is happening currently. 2, we can talk about infrastructure readiness and support. This can be demonstrated by the teams and facilities which are using this infrastructure. Health products digitalization, again, this can be demonstrated between our work and KEMSA and what you have managed to come up with a product catalog. Monitoring systems, we can always tell, and actually you will be able to see, as Waziris, you'll be able to sit down in your office and see, 1, who is working, 2, which facility is closed in that day. You don't need to call anyone. As you sit, you'll be able to see which facility is closed. There is no work which has gone. You'll be able to sit as you are, wherever you are, even at the comfort of your office, and we'll be able to demonstrate this shortly. So, again, we are talking about digitalization of the facilities, and this to say that in this component, we have managed to do, as an agency, Taifa Care Management System, the HMIS. For now, we are rolling out the Tibabu. We were working with Waziri the other week to come up with the enhanced Kenya EMR the way it is, so that Homa Bay County and Kisumu County and probably Kitui County can pick Kenya EMR. Why? As a WISE team, we cannot put all the eggs in one basket in terms of systems. For us to spread the risk, it's good to make sure that at least we have counties which are also with other systems. Again, the status is that 24 counties have various phases of Taifa Care HMI's rollout. Some of them we have done the trainings, others we have not touched anything, and we are coming to make sure that we are up and running. So as we talked by last week, we had 695 facilities fully running on the Taifa Care system against the 6,686. So meaning that now, and this week we have another around 400 which has been come on board. And we have counties like Mombasa, which are 100% automated. We have counties like Embu, which are 100% automated. We were with Waziri yesterday. Kirinyaga, which is almost 80% automated. We have Nairobi, which is around 30% automated. And we can demonstrate all those kind of automations. So when it comes to tablets in terms of infrastructure, as an agency, we have managed to distribute 19,501 tablets to these counties. Why? They are user-friendly tablets across the board. Again, we have managed to roll out biometrics in the counties. And again, we have managed to sign healthcare digitalization in the government of participation agreement with the counties. And again, we have managed to create the user interface for other private facilities. And that's to mention Metropolitan is consuming our data actually. So these are the at Shell where we are. I know when we came for the Taifa Care launch, some counties we just moved, but we are not yet actually there, but we are aligning to make sure that at least we roll out to all the counties. These are the facilities by county, by level, how we are performing, and in terms of which county is leading in terms of level 2s, level 3s, and you can see we could not bring everything. So already it's tested. It's tested in Samburu, it's tested in Garissa, in Aso County, so that no one will say there's a challenge. If it can work in Garissa, if it can work in Samburu, it means it can work in another county in terms of connectivity. Yeah, I know West Pokot will be on the way to come, although we had Afya KE in that interface. So infrastructure readiness, we are there as as a team, and we are working to make sure that at least the designs are approved in terms of connectivity. You saw teams which were coming around to make sure that they pull in terms of infrastructure connectivity in all our level 4 facilities. Again, products digitalization, we have the product catalog. As a country, and this is since independence, we can say we work together with PPB and KEMSA to come up with a health product catalog. And this product catalog, you can get it from our terminology service, and you can see any drug which is authorized to be utilized in this country is in that catalog. Again, for us to move and to achieve what we are talking about critical things, and the one is change management, whereby people are at the center. I remember I was talking with Waziri Nandi. We met in devolution, and things were not happening. And when we met, we discussed, he went back. From 200 patients in a day, he can see comfortably 1,600 through the system. So it means there is a role as Waziris you need to play. There is something you need to do so that your account moves up. Nairobi have always been calling, and it is really moving very well. So again, we need to sensitize and train, and it has been critical. And again, we have been really making sure that we have continuous support in this process. So far, this is what we do, the issues. We do normally do the first count sensitization. And at this level, we don't move fast to go to the TOT. Because after the count sensitization, when you go to the TOT, once you train people, you cannot stay with people who are not trained for long. So we make sure that at least we do that, and then we move forward. Again, we start with the dispensaries to make sure that everything is okay, and we have what we call conduct quality assessments and monitoring. So all this we have been doing, that's how we do. And for us to come in that journey, we have what we call baseline assessment, health product, to make sure that at least we customize them. We customize the inventory in the facilities. All the drugs, for you to be live, they must be in the system. So that from there, as you recruit, you can always monitor your drugs as they come. So the first thing is to make sure that we do all the drugs, all the non-farms in a facility. Again, we identify TOTs, deploy, we come up with a deployment plan and implement that plan. The other issue is about monitoring. We always monitor issues to do with end-user devices. We also monitor healthcare workers trained. We also monitor facilities digitalized by faces. And again, health facilities digitalized by faces in OPD and inpatient. So as we talk, we can talk about, we have a system which is end-to-end in these facilities. So with all this, we cannot talk about the client, we cannot talk about the patient, and we leave issues to do with data protection unaddressed. So we are guided by data protection principles, which make sure that at least at the end of the day, as we come up with systems, the client's data, who are now the data subject, according to Data Protection Act 2019, the data is well protected at that level. So that makes my brief presentation. Now I want to go to the next level, whereby I'll just show you 2 dashboards, and then I close there because for the interest of time. You can always come and see what is happening in our either point of care systems. Like now, this is our system whereby, and unfortunately my phone is behind there. I would have shown you because you have an OTP. You can always tell a health worker who has come to work and who has not come to work by using this system. So with that, also for the interest of time, we have an interactive dashboard for all the counties whereby we have started the HMIS. We can see, for example, I wanted just to demonstrate several of them. including Nandi here, because she had a lot of issues until the other day. Sorry, this is Nairobi. And with this, you can see how many patients have been seen even today. You can see how many patients have been seen today in terms of service provision. And on top of that, you can also tell, in terms of workload analysis, there is one Emily Akinyi Okoth who has managed to see 75 clients today, compared to another health worker in the county. So this one gives you real time. So there's no one who will tell you we are working or what is happening. Again, in terms of disease surveillance, you can also talk about the syndromic surveillance. You can see what, when it comes to major complaints, people come into the facility, what is the real issue? You can always tell from this level. And again, you can always